Hi, everyone. I'm hoping people are going to join as we go along here. Couple things. I'm going to go ahead and present a PowerPoint on elimination. So before we get started, I want to just let you know, I do see there's a couple of, now that we have the question and answer area fixed, I still don't understand what happened, so I'm going to pursue that. But for right now, I am seeing your questions. There was one still on the pain assessment, the video case study. I will go back into those. What I need you to do is upload the report from ATI, so I at least know when you did it and that you did it. Everyone should have a report then on there, and then I will go back into ATI to see your video responses. That being said, I don't think I'm going to continue doing it this way, but we will give you credit for what you're doing. But I do expect the questions answered on the original assignment. So this is kind of maybe a little bit of a freebie to have a chance to go back in there and fix it to the way the assignment says it should be. But I will go back to your video responses. Let's see what else. There was a question on classes. Adriana has asked that, and sorry, I don't know. I know that Mrs. Espy said they want to make sure they're still figuring out the logistics of that. So I don't know what to tell you on that one. We'll work on that. What was the other question? Catalina had a question on, and let me see if I can show you this. Okay, if you go to, so the question was the ATI learning systems, the nursing care of the children that's due this week. It's a 0. It says it's worth 0. I believe that got changed. This is what happened. Let me go back up here. If you go into your modules, and this is under my view, but it should look pretty close to the same thing. If you go under your modules, right here in this fall NVN 121 grading assignments, we had to make some adjustments. In the summer, we met with the ATI representatives, and they gave us a whole list of things that we could have you do. So we thought, hey, you're paying for it. Let's put everything in that you can do. Well, once we got everything in, we realized that these are actually not included in the PN package, the LVN or the PN package. So they're just taken off your stuff. So you don't have to do it because it's not there. Okay. All right. So that being said, let me go ahead and start with the slideshow. So this week we are covering elimination. Can you believe we are in week 10, guys? We're actually in the middle of week 10. I know people are a little on edge. We got a big week coming up next week for our country. Let me go ahead and get started on this. Learning objectives, they're really pretty simple. You can see they have to do with elimination for urinary and bowel. We're gonna talk and get quizzed and tested on urinary tract infections and risk for diarrhea. We're going to look at clinical manifestations for across the lifespan for all of this. And then also discuss the underlying principles that affect bowel elimination. So these objectives are covered, a lot are in this slideshow. Some are in the 2 case studies that you have. And I know Mrs. Gifford, she's so nice. She went through the cleft lip case study with you. And so those help to cover, both those case studies help to cover some of these objectives also, right? So look at your reading, look at the ATI video case studies, look at all of the things that's in there, because that's where, again, we pull questions from, all right? So what is elimination? Elimination is the excretion of waste from the body by the GI tract and from the renal or urinary system. Bowel elimination occurs as a result of food and fluid intake and ends up being passed via stool or solid waste products from the food through the rectum in the colon. The fecal material remains in the rectum until you have an urge to defecate. Bowel elimination control depends on multiple factors, including muscle strength and nerve function. So think about going across the lifespan, what that looks like, okay? Urinary elimination occurs as a result of multiple kidney processes, and it ends up with the passage of urine through the urinary tract. When the urge to void occurs, urine is passed from the bladder through the urinary sphincter, urethra, and meatus. It's called micturition when you eliminate your urine or expel your urine. Primary interrelated concepts are fluid and electrolyte balance, which you covered last week. Tissue integrity and nutrition are some of them. But obviously you can think of, I don't know, offhand I'm thinking psychological, let's see, I can't think of more off the top of my head, but we'll go over them. So the scope of elimination. This concept includes normal or expected the physiological process of waste formation and excretion by the GI and the renal systems, as well as problems associated with the excretion. So it goes from waste formation to waste excretion. The kidneys are responsible for removal of metabolic waste and other elements from the blood and in the form of urine. The GI tract is responsible for removal of digestive waste in the form of stool. The excretion of urine and stool normally occurs under voluntary control. So we can, as adult, we can hold it, right? So the scope of this concept also includes the impairment of elimination, which is a wide range of problems and conditions that contribute to impairment of elimination. At this point, I would suggest that if you have, I'm not saying you have to go back to anatomy, physiology, and like know this for the test, but obviously if you go back and find a good video, which I have included a couple good YouTubes on your Canvas shell in the module this week. If you go back through there, it's obviously going to help you connect the pieces better, right? So in this slide, we're talking about what are the critical attributes and antecedents or preceding events that are presented when you're talking about bowel elimination or bladder elimination. So these are the normal events, okay? So for bowel, critical attributes or characteristics are you have to have the presence of stool or feces, the passage of stool, formation of stool, color of stool, frequency of stool passage, and retention of stool. The preceding events is, again, the urge to defecate, possible intestinal cramping, feeling of fullness in the rectum. Those are things that are all preceding events to eliminating your bowel or elimination, bowel elimination. For urine, it's again, presence of urine, passage of urine. These are characteristics of retention of urine, color, frequency, amount. Preceding events are urge to urinate, feeling of fullness, and possible contraction of the bladder. So quick review of the anatomy and physiology kind of thing. Again, go back and review these, but just so you have an idea in your head here, colon, rectum, anus, peristalsis, sphincter, gastrocolic reflex. Look those up, know what they mean, okay? They're gonna help you connect the dots. This is the large intestine, and you can see here, so here's from the ileum, the ileocecal valve, and then stool is product, you have the appendix, stool comes up and over and down and out the anus. Here's the external anal sphincter muscle. Just offhand, in infants, you can have infants born, and it can be an emergency where these I guess these do not attach to the wall, the abdominal wall, like they should. So they can actually be dropped down and twist, and that can be an emergency for an infant. You don't know it at first, but so. Two overarching principles of bowel elimination. So digestion and formation of stool. So for digestion, you have the breakdown and absorption of nutrients from foods ingested. And you have the elimination of waste from this process. The esophagus, stomach, and small intestine is involved in digestion and absorption of our nutrients. The process of waste formation occurs in the colon. Smooth muscle within the intestinal tract stimulates peristalsis, which helps to move the waste product known as stool or fecal matter. So again, we have a lot of these arrows, but it's just showing you the continuum, right? The scope of what bowel elimination is. So you have in the middle, the normal stool pattern and consistency. That's what we want to see with everybody. But then there's two ends of the spectrum. So you have the diarrhea and you have the constipation. So normal urinary elimination involves the process of waste formation or production of urine and the excretion of urine involving several specific structures. So you have the kidneys, the ureters, the bladder, the urethra, and they must all function adequately in order to expel the urine. When you start talking about alterations in elimination, they can occur with urinary and gastrointestinal. So, and represent a wide spectrum of problems. Most problems and conditions can be grouped by common themes. So you have, let's see, incontinence, where'd it go? Incontinence or continence, retention, okay, and discomfort, infection, inflammation. You could have neoplasms or tumors, and organ failure. So here it's just showing you again a concept map looking at elimination. So if you look at elimination, you have renal, you have intestinal, okay? Recognizing when an individual has a problem. First of all, you have to collect the patient history. You have to use open-ended questions, obtain information from the patient's elimination patterns, being respectful and sensitive of how you ask it. Let's see, today, trying to think of, because we're actually going to have working on elimination in the RN program in clinical or in their whole thing too. So everybody's working on the same thing. So our clients today ranged from someone being extremely nauseated to someone having bloody diarrhea and going to go for a test to find out what was going on. And what else? We had another woman with a UTI, an elderly woman. So lots of, you are going to see this, right? This is part of everyday life. Okay. So conducting a history is a first step to understanding problems associated with elimination. Ask about patterns of urinary and bowel elimination, including frequency, appearance of stool and urine, and associated symptoms. Common symptoms directly related to elimination include alterations in elimination patterns. So changes in appearance, frequency, or quality of the stool or urine. Are they uncomfortable? Are they having pain when they void or stool? Have they had a change in diet? So I can tell you a story with, so yeah, you just have to understand if they've had a change in diet. My dad, probably about 3 years ago, had to have his teeth, had to have dentures put in. So he, up until that time, he ate pretty well. But once he had his dentures put in, for whatever reason, whether it didn't feel the same or what was going on, they didn't fit right, he never really ate the same way again. We had to, get him to eat smaller portions, and he couldn't eat chicken because of this. So that kind of change in their dietary intake is huge, right? When you think about it, especially when you get into your elderly clients. So change in health status. Did someone recently have a brain injury? So they're recovering from a brain injury. And so they might have problems with their cognition, mobility. What's their functional ability? Are there any new medications they started? Maybe their blood pressure medicine was changed and now they're taking a diuretic at night. So how does that change their elimination pattern? And again, looking at voluntary or involuntary, are they continent, or are they do they have incontinence? So this here is meant to be what I hope that you would take and play around with and come up with what objective data you might see and what subjective data you might see, okay? So cluster the subjective and objective data indicative of alterations in intestinal elimination, and make emphasis on what their elimination pattern is, their activity, rest, safety, in food and fluid, their nutritional status. So this helps you come up with a list of risk factors for this person, right? If you do a really good assessment, get this data together, you're going to come up with some risk factors. For some patients, you're going to have to end up doing some lab work. For example, a urinalysis and culture and sensitivity would be appropriate for a patient with suspected urinary stones, retention, or an infection. Radiologic testing and ultrasonography for stones or other structural abnormalities may also be performed. We, as nurses, if they have them, can do the bedside bladder scanning to detect urinary retention that can result in a UTI. Again, I'll go back to what happened with my dad. He went into the hospital for his hip fracture. I'm sure, but I don't know because nobody can go into the hospital nowadays. He must have had a Foley for the surgery. They took out the Foley. He went to the rehab center within a matter of 2 to 3 days, right? So he goes to the rehab center and he's there 5 days, and he continually is complaining of back pain, continually. So anyways, long story short, we bring him home to our house. He ends up getting worse. He goes back to the hospital. They end up emptying his bladder for almost a liter of fluid, 1,000 cc's. And that was after he had some incontinence already. So at that point, his bladder was so over-distended, they did not take out the Foley catheter after that. But you can see that that was, in my mind, a nursing miss and a doctor miss, okay? So whose responsibility was that if you have an 87-year-old man who's been taking narcotics, who's not used to them because he didn't take them on a normal basis. He had surgery. He probably had urinary retention at that point. He had BPH, which we'll talk about that here. So all of those things set him up for this, but nobody took the time to figure this out. And that was probably why he had such extreme pain, horrible pain. A stool culture and sensitivity may be done for patients suspected of having C. diff infection. C. diff, you'll hear that talked about, and we've talked about that in class. I'm pretty sure in 119 we talked about it in talking about PPE. This infection often causes severe diarrhea in older adults who have received antibiotic therapy due to a decreased immunity, and is easily spread from one patient to another. So this is the one we talk about, proper hand washing. Doing just the alcohol on your hands is not suitable. You have to go do the actual scrubbing of your hands with soap and water. So this is a little acronym that actually, it's part of a video that I posted for you. So hard to avoid, and just thinking about anything around urinary elimination, okay? So H for hormone changes. So people who are pregnant, remember, so pregnancy, menopause, birth control, all of those can change the normal flora for a woman and set her up for a UTI and having problems with urinary elimination. Antibiotics, again, changes the normal flora in the bladder. Renal stones, obviously blocks the urine from draining out of the kidney. Diabetes, compromised circulation in the renal system. Glucose is in the urine. Bacteria likes glucose. Decreased urinary retention. Toiletries, bubble baths, especially, you know, it goes back to, I think of little girls, you know, they love their bubble baths, and women do too, but loves lots of bubbles. Well, if little girls don't get everything all rinsed off, that sets them up for a bladder infection. So powders, perfumes, scented tampons, and sanitary pads. Obstructive prostatic hypertrophy. So BPH, this is what I was saying with my dad, and a lot of elderly men have this, or men in getting into their late 50s, 60s. And it actually, my little arrows are wrong there. It's actually increased urinary retention, right? In antimicrobial fluid. I'll fix that, guys. So BPH is also called enlarged prostate. It's a common condition as men get older. The enlarged prostate gland can cause uncomfortable urinary symptoms, blocking the flow of urine out of the bladder. It also can cause the bladder, it can cause a person or the male to have bladder, urinary tract, and kidney problems. Vesicoureteral reflux, VUR, is in the pediatric population. This is where the urine backflows from the bladder to the kidneys, in that there's a valve defect. We actually, working in the nursery, had infants that we knew when they were born, because they could see it on an ultrasound, that they would have a kidney already enlarged. And it was from this. So what we would do is send the infant, would be started on a prophylactic dose of like Keflex, some sort of antibiotics. And the infant would take that, and then they would get followed up to see if it would resolve on its own or if there was going to have to be something done. This condition is more common in infants and young children. Urine, which is the liquid waste product from the body, normally should just flow one way. But again, this flows back up into the kidneys, which allows the bladder or the kidneys to get enlarged. Overextended bladder, already talked about that. Think about, anybody after surgery, patients, the medication they're receiving for pain can cause somebody to not be able to void. So if you have that going on, they might have a PCA pump going. You as a nurse maybe think about, hey, they haven't really voided, they keep trying to void, so maybe we need to turn that off, find a different pain med. And then you have indwelling catheter, invasive procedures, intercourse, spermicides can cause problems, person incontinent, decreased immune system, and viral and fungal. Signs and symptoms of a urinary tract. Don't know how many of you have had a bladder infection, but if you've ever had one, you don't forget it. Pain when voiding. You constantly have to feel the need to void, even though you can't. Your urine might be odorous, it might be concentrated, cloudy. In here for a kidney infection is the CVA tenderness that we talk about when you're doing assessments. You can have bladder spasms, fever, increased white blood cells in the urine. The geriatric population, this is something you will see on a test, folks. Geriatric population, sudden confusion, they're falling a lot, they're agitated. They may not have a fever, but they think they have to constantly need to void. I'll go back to this slide and fix it when I think these two slides need to be fixed. So, okay. So who's at risk? Notice the risk factors that place individuals for elimination problems. Oops. These populations are really all individuals, regardless of age, gender, or race, are potentially at risk. Incontinence of either the bowel or bladder can occur as a result of aging when the pelvic floor and muscles become weaker. It may also occur in adults who have a neurologic disorder such as a stroke, dementia, multiple sclerosis. Excessive use of laxatives may cause diarrhea, incontinence. Diarrhea also results from acute GI infections, such as the gastroenteritis and chronic inflammatory bowel disease, such as Crohn's. Irritable bowel syndrome causes frequent diarrhea and constipation or intermittent episodes of both. That doesn't sound fun. Urinary retention is often a problem in older men. We've talked about it, BPH. This overgrowth of the prostate blocks the bladder neck and prevents urination or complete bladder emptying. Retention of stool or obstipation is also common in older adults who have decreased peristalsis and lack adequate dietary fiber or fluids to promote the fecal passage. They also lack exercise, and they might be taking certain medications such as the opioids, the diuretics, psychoactive drugs that can also contribute to the constipation. So really paying attention to their diets, offering them, making sure they're drinking enough water, maybe some prune juice here and there. Spinal cord and brain injuries or diseases often cause involuntary control or retention of both bowel and bladder. You can have a neurogenic bowel and bladder. Renal and urinary health problems can alter urinary elimination depending on the type of the disease or the disorder. For example, obstructions such as kidney stones may prevent urine from reaching the bladder. Actually, ureteral stones may prevent urine from reaching the bladder. Chronic kidney disease can also change the amount of urinary output, and depending on the stage of the disease. In the end stage, the patient experiences oliguria or scant urine, that's less than 30 mLs an hour, or anuria, which is absolutely no urine because the kidneys have lost their ability to make urine. Consequences of the loss of control of urine or bowel. These are just a couple, right? It can lead to skin breakdown, changes in daily activities, changes in social relationships. If you have someone who is used to, I think women find themselves in this situation where they end up maybe losing control of their bladder, just involuntary. So they have to wear some sort of diaper. I'm sure it happens to men too, but so you have risk for damage to the tissue integrity. If not removed from the skin promptly, the stool and urine can cause irritation, fungal infections, skin breakdown. Loss of bladder and bowel control can also lead to depression and anxiety, right? If older adults in both healthcare and community settings may have to wear undergarments or briefs to prevent soiling their clothes. If not treated, patients with prolonged diarrhea may develop fluid and electrolyte imbalances, especially dehydration and hypokalemia, so a decrease in serum potassium. These problems are serious and can be life-altering, life-threatening. Urinary and bowel retention can result in a buildup of toxin and waste products. And I actually talked to you about retained urine can cause a rupture bladder, but you can see if my dad had 1,000 mLs in there, the bladder can stretch quite a bit. Some more consequences of bowel retention. Causes ignoring the urge to go or decreased peristalsis, causes the retention of the stool. Stool dries and hardens, you can have constipation, and you can have someone impacted. So you can look at this x-ray over here. I know that's a drawing, but that stool is not going anywhere. Nursing problems related to elimination. I came up with impaired or altered elimination, impaired tissue integrity. I'm sure you can think of others having to do with nutrition, psychosocial, self-management. So think about those. So providing an appropriate nursing and collaborative interventions to optimize elimination. I want you to take some time and think about using the nursing process to construct some collaborative plans of care, or look at setting up some concept maps and or the latte papers. I don't know if you have all been showed those, but if not, let me know. I actually can post an empty form, but they actually help you understand what that person looks like, what the assessment you would be looking for, what are some tests involved, what are some treatments, and what are some education that you could have done with the patient. It's called latte. Clinical management, primary prevention, hydration, adequate dietary fiber, regular toileting practices. You might say to the person, okay, we're going to have you right when you wake up in the morning, we need you to empty your bladder. And you would set up regular times, encourage regular exercise, and avoidance of any kind of environmental contamination. Nursing interventions, assessing, and sorry guys, I need to fix this slide too. I'll go back. Assessing, maintaining, and monitoring their INO. Again, you want to at least the person putting out 30 mLs per hour. That's minimum for an adult patient. For babies, we like to see 2 mLs for the tiny ones per hour. Administering medications per order, educate, monitor for any complications. You might have to collect some labs. So a UA is a urine analysis and a UC is a urine culture. Again, if you're going to collect a culture specimen, you need to make sure that's done before the patient gets started on antibiotics, right? Remove the catheter per MD order. In the hospitals and in the long-term care facilities, leaving these catheters in it has been proven to set the person up for a bladder infection and sepsis ultimately. So making sure that if the client can have the catheter out, that it gets taken out. Encourage 2 to 3 liters of fluid per day. It just gets the system flushed out. Bactrim can develop the crystal urea if you're not taking enough fluid. So Bactrim is something that it's a sulfonamide that is given for UTIs. Person can take it actually on and off for a long time, but it can, if they're not drinking enough, can cause the crystals in their urine. Encourage voiding every 2 to 3 hours. And for pain, they can do the warm sitz bath, heating pad, peridium, which making sure that the patient understands or the client understands that it is going to turn their urine orange, that it's not bloody, it's just orange, and that's how the medication works. It's an analgesia. So take all their medications, all of them, wipe from front to back for the female patient, void after intercourse, loose underwear. I find especially women have a problem when they wear the tight yoga pants, and maybe basically they wear the tight yoga pants. They might keep that on for a couple hours during the day. If that's done the area doesn't get enough air to it, and you're going to run into getting UTIs or kidney infections. So wearing looser underwear, loose cotton is better than the silky. No bubble baths or perfumes, and change tampons and pads often. Avoid alcohol or caffeine. Void every 2 to 3 hours, and drink at least 2 to 3 liters of fluid. Some clinical management, secondary prevention screening. Colonoscopies detect colon cancer. You could have a doctor order for occult blood screening, and then the prostate cancer screening. Okay. So general discussion questions: who should undergo? Think about who should undergo these procedures. How often should each be done? Look at how often for these prevention screenings and who should be having them. What factors inhibit a person from having these screenings done? So you guys answer that, all right? Some pharmacotherapy for bowel elimination. I'm sure you all have seen most of these products. So you have laxatives, different types, stool softeners, and you'll have a combination. You could have a patient having 2 or 3 different ones. They could take a Clolase, they could take a Senecot, and then they may take a Miralax. That might just be what the doctor orders because maybe they've been constipated or they're taking a lot of narcotics. Antibiotics, antispasmodics, and analgesics. Some surgical interventions to help with bowel elimination: colectomy, colostomy, or ileostomy. They can have a rectal prolapse repair and also a hemorrhoidectomy. These are just a couple of the different surgical interventions. So again, interrelated concepts. You see these, all of these have a direct effect on elimination, right? So the primary interrelated concepts are fluid and electrolyte balance, tissue integrity, and nutrition. These are some clinical exemplars. They are in your book. The exemplars for alterations in urinary elimination include conditions across the lifespan, ranging from bedwetting, which the child may just has problems learning to control urinary elimination, to incontinence, which may occur as the person ages. Bowel function also spans the life cycle, a variety of issues, such as infant, there may be a structural problem. There may be strictures or fissures that the child is born with. And whereas functional issues such as constipation may occur as the person advances. You can have constipation problems with children too, right? Where they could develop a megacolon. So just be aware of how these are across the lifespan. These are 2 links that I put here, but they are in your module on campus, in the module for the week, okay? They're both really good. Like I said, that one slide I got from the urinary tract infection, and then this is just a simple slide on, it's a YouTube on bowel elimination. So we have a case study here. This is Ms. Amanda Doyle. She is 61 years old, white female with a history of type 1 diabetes, and has been bothered by osteoarthritis for the past several years. So her diabetes is well under good control with her diet and insulin, but she recently has found herself taking more ibuprofen twice a day to manage the arthritis pain. For the past 6 weeks, she has experienced abdominal pain and increased frequency of bowel movements. Her stools are loose and not formed. Quite frequently, they are a liquid consistency. Her life has been altered by the frequency of having to access a toilet because of the diarrhea. She has rectal bleeding and irritation from the frequent bowel movements, and she has suffered from abdominal pain at night as well as during the day. She reported these symptoms to her primary care provider, who referred her to a GI doctor, a gastroenterologist, for evaluation. So he ordered an occult blood test, which showed blood in her stool. A stool culture was done to rule out parasitic infections, and this was negative. So because it had been 9 years since her last colonoscopy, a colonoscopy was ordered to rule out pathology with the colon, such as ulcerations or tumors. This screening test was also negative. So the nurse practitioner suggested that Ms. Doyle change her arthritis medication from an ibuprofen to Celebrex. I think it's celecoxib. Within 2 weeks, Ms. Doyle has normally forming bowel movements and no abdominal pain. So the symptoms described by Ms. Doyle are consistent with the abnormal patterns of elimination. The diagnostic tests performed are routine, given the symptoms and the time frame since the last screening test. Non-steroidal anti-inflammatory drugs, NSAIDs, do cause GI distress, bleeding, and diarrhea, particularly when you start taking them at the high doses and when they're not administered with food or milk. So celecoxib or Celebrex is a COX-2 inhibitor and is indicated for osteoarthritis, particularly when GI inflammation is experienced with the other NSAIDs. So that's just a quick case study with the analysis. Now, from here out, you can look at this study on Mr. LC. This is a Native American man. He's from a Pueblo tribe in northern New Mexico. He and his wife and family drove 50 miles to take him to an Indian Health Service hospital because of his deteriorating health. So you can go through this one, answer these questions. I'm not saying it's an assignment that's due. I'm saying think about these, okay? Go through them. Which physical assessment findings are most concerned to you? So I have them there, and then I have the subjective data, and then ask you some more questions. It's kind of like a little mini case study, okay? It is a case study, but it gives you another perspective on this gentleman has colorectal cancer, okay? So take a look at it, go through it, answer these questions. It really will help you get another perspective. I really think the case studies do bring that home for everybody. All right, so I think that is it for me. I was kind of hoping people were gonna come on, but I get it, everybody's busy. So that being said, hopefully people watch this. I will upload it to the module, and I hope you guys have a great night. I'm gonna go ahead and look at, I know I did get a couple of questions and I need to look at those. All right, guys, well, thank you, and I will talk to you later, okay?